Hello, everyone. This is Jeanette Gass from Iasp, and I would like to welcome you to today's webinar, Back Pain Treatment and Exploration of Risk Stratified and Stepped Care Models. Today's webinar is the latest in a series related to the 2021 Global Year about back pain. Before I introduce our moderator, I wanted to bring your attention to some information that appears on these slides. There are several ways to participate in the webinar today. After the talks, we'll have a Q&A session, and you can type your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like. If you have a general question about logistics or would like to share where you are joining us from, you can use the chat box. We will also be recording this webinar, and it will be available on the IASP website. You can also tweet using Global Year 2021 and follow at IASP Pain on Twitter. Next, I would like to let you know about some upcoming IASP events. Topical workshop submissions are now open for the 2022 IASP World Congress on Pain in Toronto, Ontario, Canada, and registration will be open soon. We also invite you to join IASP to access more education and resources available only to members. Now I would like to introduce our moderator, Dr. Gabrielle Paget. Dr. Paget is a clinical psychologist and pain researcher in the Department of Anesthesiology and Pain Medicine at the Université de Montréal. She is also a scientist at the Research Center and is a Junior 1 research scholar She is a member of the scientific committee of the Strategic Initiative on Low Back Pain and co-leads the strategic initiative on the judicious use of opioids in the Back Pain Research Network. Her line of research examines the bidirectional associations between stress and pain, the trajectories from acute to chronic pain, and the impact of mental and physical comorbidities on chronic pain treatment response. Now I will turn it over to her to introduce our speakers.
Good morning, afternoon, or evening to everyone. We're really happy to see you joining this webinar. We have three fantastic speakers today, so I'm really excited to get this started. As Janet said, we will mainly keep the questions for the end, so after the three speakers gave their talk. So first up will be Alice Kongstedt. So she's a professor in musculoskeletal research in primary care at the Department of Sports Science and Clinical Biomechanics at the University of Southern Denmark, and a senior researcher at the Chiropractic Knowledge Hub. Her research interests concern spinal pain with a focus on primary care. And she's led the development of GladBack, a program for implementation of patient education exercises to support self-management in people with persistent back pain. So she'll give us an overview of different models for back pain. So Alice, the floor is yours.
Thank you, and thanks a lot for the invitation for me to be here. I'll just start sharing my screen, and I hope you can all see my slides now. It's a pleasure being here and talking for such a very international audience, as I can see from the chat that this is. And as was just introduced, I will talk about more general principles of models of care for back pain. So I would guess that most of you who are listening today, you are very aware that we have a high demand and need for high value back pain care. Because very many people suffer from back pain, have activity limitations, they're very much care seeking for back pain, and we have had some poor and harmful solutions. For example, is back pain a main driver of the opioid crisis that has developed? So we need to find ways to make sure that people are offered the best available options for back pain. And models of care are ways to plan and describe how healthcare services are provided to people throughout the stages of their condition, with the aim to ensure that patients and people have the right care at the right time, by the right people, and using the right resources. So that would involve or include a lot of more specific, maybe objectives of a model of care, including these adapted from the NHS, that care is available, is accessible to everybody, that we have models of care that take inequality and health into account, that patients have high quality patient-centered care, that is cost effective. So models of care really have a complex aim and will surely involve very many stakeholders. So models of care really works on a lot of levels, with stakeholders being involved and responsible for delivering care, including both clinicians, but also healthcare systems and governance that all plays together. Today, I will focus on the decisions made in models of care at a clinician level in the delivery of care. But we have to keep in mind that that can only work well if the other parts of models of care, the organization, the structure around healthcare delivery is also supporting the optimal model of care for clinicians. So if we start with looking at what is the right care for people with back pain, and my focus will be on non-specific back pain, there is actually quite large agreement what people with back pain should be offered. And here are some overviews of clinical guidelines, interventions that are highly recommended and recommended to consider. So on the top of the list of recommended interventions are things like information and education, promoting of active and active lifestyle and exercise therapy. And there are also other things like manual therapies, psychological therapies to consider in the care of back pain. So really much focused around activating treatments. For specific subgroups of patients with more complex issues of back pain, there are also recommendations about psychological behavioral treatments and multidisciplinary programs that should be offered to those with specific needs. If we have a brief look at recommendations for musculoskeletal conditions in more broadly, it's quite clear from clinical guidelines that there are principles of management of musculoskeletal care that are the same for many types of conditions. So here's just a little view on some recommendations for osteoarthritis and back pain, but it also goes for other conditions such as neck pain, shoulder pain, that these highlighted principles here are the same across conditions. So patient-centered care based on the identification of biological, psychological, and social factors, and providing education and information and promoting physical activity is really at the center of musculoskeletal care, including back pain care. There's also quite large agreement about the things not to recommend and not to use routinely for back pain. And that includes imaging and some passive modalities. And you'll also see on this list a lot of pharmacological treatments. So we are really facing a paradigm shift in back pain away from pharmacological treatment and pain medicine and towards interventions that engage people more in their own in their own treatment. So with this brief introduction to what is the right treatment, I will move on to what models of care really add to the clinical guidelines, and that is to be more specific about the right patient and at the right time in ensuring a high quality care. And I will base that on this, mainly on this paper that I've written with a group of good colleagues and people, and you will hear later from one of them, Jonathan Hill. So what I will do is to introduce two main principles of models of care for making treatment decisions in back pain, and one is step care and one is stratified care. And the principle of step care is that all patients would start with having some minimal care when they enter healthcare systems. And only those who do not respond sufficiently to that, they will have more extensive care. So the principle of step care is that treatment decisions are informed by response to prior treatment, and everybody would start with what could be the most minimal kind of basic care. There are some assumptions to this, and these include that many patients would be expected to improve with minimal care for step care to work, and there are no risk of harm with waiting for to see if you respond to the first levels of care. And of course, there's also an assumption that there are some effective treatment for those who did not respond to minimal care and moved up the ladder to more comprehensive care. The principles of stratified care is that treatment decisions are informed by the expected outcome of people based on known prognostic factors. So people who are predicted to have a poor outcome with minimal care, they would from the beginning be moved into a pathway where they have more extensive care. So the idea is that we do not wait and see if people would respond to to minimal care if they have a profile suggesting that they would not. The assumptions for that is that first of all, of course, that patient profiles can be identified early on that need more or less comprehensive care, and again, and that effective interventions exist for each of these profiles. It's also an assumption that the risk of poor outcome would truly be reduced by an early intervention. Another type or take on stratified care would be stratification into not different levels or different degrees of extensive or not care, but different types of treatments, for example, into exercise therapy or manual therapy. And that would assume that patient profiles can be identified that are more likely to respond to one of these treatments than to the other. For both of these types of making a treatment decision within each level, within each of these green boxes, there are some specific decisions to be made about this exact type of treatment to offer to an individual patient. And that could in principle for both types of care, models of care, be guided by potentially modifiable prognostic factors such as disability level, people's fear and worries, people's pain cognitions. But that does not exclude also being aware of non-modifiable prognostic factors, because we know in back pain that there are risk groups based on non-modifiable factors such as educational level or other social factors that may indicate that somebody would need more support, but it would probably not directly inform a clinician about a target for treatment. So how does all of this fit with back pain? If we look first at the assumptions, that I mentioned for the step care approach, no harm of waiting. I think that it's fair to say that it talks to it supports that there's no harm of waiting, that we know that recovery rates without treatment in back pain are high. And we also know that back pain is not a progressive condition in the sense that there are some disease activity that would progress if not treated. Talking against no harm of waiting is that we also know that some of the negative prognostic factors in back pain, such as unhelpful behaviors and beliefs, they can be established quite early on, and that therefore, it might make sense also to address them early on. We also know that time off work, if that is prolonged, it will increase your risk of not returning to work. So I think overall, it's fair to say that there's no harm of waiting a short period of time, but if it becomes very extended, we increase risk of particularly non-return to work, but probably also risk of prolonged disability. We also had an assumption that effective treatments exist for people not responding to minimal care. And yes, we have trials demonstrating that patients with long-lasting back pain who had previous care, they can, on average, have benefits from treatments beyond basic usual care. For this stratified care approach, we had the assumption that we can actually identify patient profiles with different needs. And yes, there are prediction models that are useful for predicting poor outcome, but we also know that prediction in individuals is very difficult to do precisely, and particularly very early after back pain onset. Again, it's fair to say that there are effective interventions for high-risk patients with a complex profile, so there is something to offer at different levels of stratification, and I'm sure you'll hear more about that in later sessions today. The last example about stratification into different types of treatment, we must say at the moment we do not have replicable examples of that really working in back pain. So what would this look like more precisely in clinical use for back pain? If we consider people with very recent onset, less than 2 weeks, could be a marker of that, all patients should have information and advice. And as it's difficult to predict at that time who might need more, and many will improve with minimal care, it's probably wise for this very recent onset back pain to use a stepwise approach, so everybody starts at this level. For people who consult later than that, or who did not improve with information and education for recent onset acute back pain, we would then move into a stratified care approach. So in the stratified care approach, people would be assigned to different pathways of treatment depending or according to their prognostic profile that I'm sure you will also hear more about later. But the idea is that there are, for very acute onset, a stepped approach, but later a stratified approach is recommended. And then again, if that pathway chosen here is not sufficient, that would move people into a higher level of recommended care for more complex back pain, or in case of radiculopathy, maybe surgical assessment. For all of these types of treatments and pathway, we know that there are not really curative treatment for back pain in the sense that people would be cured for good. So all of these should support people's self-management, both alongside being in contact to healthcare providers and in between such contacts. Other than the aspects that are included directly in these models, clinicians' decisions must also consider people's individual preferences and personal resources, and their previous treatment experience and self-management success. We know that back pain is very often a recurrent condition. So of course, the knowledge we gain from talking to people about previous experience must also inform decisions made. Lastly, I'll just make a few comments about study designs for looking at models of care. So we have a design that some of you may know as a subgroup system, RCTs. And this is the design that we would use if we want to test if one model of care is more effective than another. So comparing types of models of care. So far, there's no direct comparison in back pain of step care and stratified care. but there are tests of stratified care that you will know more about later. If the intention is to study if the classification system is effective, we would need to randomize people with different patient profiles, so that patients with a profile A, for instance, they would have both treatment A and B, and we will test if they respond, if they have more benefit from treatment A than B, and vice versa. So in very short terms, models of care for back pain, they suggest that all patients with back pain should have information to help them understand and manage their back pain. And then shared decisions should be made about the possible addition of other treatment or interventions. And that should consider the duration of back pain, at what stage. Is it very early on you see a patient, or is it later in the course of symptoms? Their previous response to treatment in a step care fashion at that level, and their prognostic profile when moving into a stratified approach. So with that, that was my brief and quick introduction to models of care in back pain. And I would like to thank for your attention to this talk.
Great. Thank you so much for explaining us the difference between those two models in a very detailed way. And we understand from a research point of view, there's still a lot to be done so we can better understand in the real world how these models can be effective. There might be just one question in the Q&A that I would ask right now before we move on to the next talk. So Leslie Singer is asking, when you see there are psychosocial variables, would you still wait the first 2 weeks or start stratified care right away? Is there any difference between those two approaches?
I think evidence suggests at this point that for different types of prognostic factors, also the psychological factors and social factors, in the very early stage of back pain, the prognostic factors are not very accurate, maybe because it is actually very common to respond with fears and worries about back pain and with high degrees of activity limitation if you have a very acute episode of back pain. So it is difficult to differentiate between those who need particular these factors particularly addressed at that point and those who do not. So in a very early phase, I don't think that psychological factors necessarily indicate that there is a particular need, but of course the basic information and education should always address individual people's worries and cognitions, but I think that could be part of and ought to be part of basic care, that we take into account the preconceptions and worries that individual patients meet with.
Fantastic. Thank you. Thank you very much for this talk. So our second speaker this morning is Jonathan Hill. He's a physiotherapist. He qualified at the Manchester Royal Infirmary in the UK. That's where he also did his master's degree in physiotherapy. Then he went to do some clinical work in the UK, India, and Australia, and then he returned to begin his research career at Keel in the UK. So he completed his PhD in 2007 when he developed and validated the very well-known Starback risk stratification tool. And this is where he conducted more research for his postdoc. And so if you haven't seen the Lancet paper in 2011, I really encourage you to go and read it. And so today he's going to talk to us a little bit more about evidence for stratified care. So Jonathan, you can go ahead.
Thank you very much, Gabrielle, for that nice introduction. And hi everyone. I'm just going to share screens, and hopefully this is going to work nice and smoothly for me and allow me to show the presentation. So, Gabrielle, can you see that all right?
Yeah, just maybe in presentation mode. Perfect.
Great. Good. So I'm going to talk to you about two things mainly. I'm going to talk about the start back approach and what's the sort of summary of where we're at with that. and then talk to you as well about the results of this trial that we've just completed called the Keel Start MSK trial, which has been an exciting project. It's been 6 years, and where we've got to is to finally get some results of how that's going. And we're looking at, we were looking at what's the clinical and cost effectiveness of pushing the whole kind of idea of risk stratification beyond back pain for the 5 most common musculoskeletal conditions. And that's also to look at for necks, knees, shoulders, and for multi-site pain. And the context of this trial was to try and test that in general practice. So what happens when we give GPs within the medical record system a template that allows them to do the risk stratification and then to get matched treatment recommendations to try and nudge their decision making so that it's a little bit more guideline adherent and they actually make the right decision, and we help the patient to get to the right place at the right time. So that's the trial that I'm going to talk to you about. But first of all, I'm going to just go back and start, just let's get our heads clear around risk stratification and how I see it. And one of the things I think is really useful is to look initially at risk stratification outside of healthcare and how it's done elsewhere. And I've come across a really interesting example, which is one of my good friends is now working in the local fire service here in Derbyshire, where I live in the UK. And essentially, when you phone up and a 999 call in the UK, and you say, I need the fire engine, the person on the end of the call has an automated risk stratification process that is helping to decide what their targeted response is going to be. So do they send the fire engine with the long ladder to get up to the high-rise building? Are there chemical substances or factories nearby, which means they need special equipment? How many crew members do they send? And they have a separate model for domestic properties and a different model if it's a commercial property. And the information that sort of populates that model is around previous incidents that they've been to, geographical information about road sizes and building sizes and all that sort of thing. And that all informs then this targeted response. Now, recently, they've been also doing something locally where they go in and do these things called safe and well visits. And fire personnel go into people's houses and they review if you've got the right smoke alarms and the right escape routes and all that sort of thing. And they interestingly found that their risk stratified model that they had for the emergency system wasn't working well at all for these safe and well visits. And they had to redo their risk model so that there was a lot more modifiable factors involved in that. And that's really interesting because it gives us a great example outside of healthcare about some key lessons around risk stratification. And let me just give you what I think are some key points here. Firstly, we noticed that they use risk status in the fire service at a system level. It's a little bit late if you get the fireman turning up at the fire with all the wrong equipment and with the wrong size ladder. It's too late, too little, too late. And we haven't therefore, what they've done is they've tried to get the system level thinking so that the response is appropriate. And I think that's helpful for us as well when we think about the healthcare context. The other thing is that we see it's directing there and tailoring the decision that's made. And that's something that's applicable for us in the healthcare world. The thing that you're trying to decide on, the decisions, the options, the treatment options in our case, will affect the risk model and whether you allow modifiable risk factors, for example, or whether you go for non-modifiable risk factors. And in the example in the fire service, that initial response, they've got a lot of non-modifiable risk factors, but when they come to going into people's homes and advising people, then it's much more about where are they storing equipment? Do they have the right access and the right fire escapes and the right smoke detectors? All those things that are modifiable really, really make a difference. So it's just important that we understand that, because as we then go to something like Startback, there's a really important thing we've got to get our heads around. What was Startback actually what were the options? And what were the risk factors that we involved? And when you look at StartBack as a tool, it only has treatment modifiable risk factors. There was a decision made not to include any non-modifiable factors. So things like, in this box at the bottom, things like employment status, previous surgery, the duration of symptoms, comorbidities, if the person has lots of those, if they've had lots of previous pain episodes, all of those things we know are hugely predictive, but they're not in the StartBack tool. And the reason for that was that we wanted to give clinicians a tool that when they had a risk status for an individual, they would know what they could treat and what they could do about it. And we even went beyond that. In StartBack, we really wanted to know what was the psychological risk factors, the psychosocial factors that would really mean that a person perhaps wouldn't do well with just routine physiotherapy, but needed to go to a physiotherapist who was upskilled to be psychologically informed and really manage the complex and challenging problems. So that's just worth knowing that we were particularly focused in terms of treatment options around a high risk treatment option that was around upskilling physiotherapists, mainstream physiotherapists, to be psychologically informed in treating those challenging cases. And we had a subscale within the tool to help identify those patients. What we've had over time is then lots of evidence around whether that prognostic tool is working, and we've had it tested in lots and lots of different studies. It's in 45 languages, and we know that that risk model is working. But as we've heard from Alice, it doesn't work quite so well in certain contexts. And when people take it out of the context in which it was validated originally, then you get problems. And it's not working very well in the emergency department because the psychological factors aren't settled down and they're not very stable when they're in the very acute stage. We've gone on from doing the research on StartBack at Keel to also looking at research around, does a risk stratified approach work in sciatica? And we found it wasn't effective. We've recently looked at the START-MSK trial, and that's taking it to the 5 most common musculoskeletal conditions. I'll show you what we found in a minute. And we've also had a backup study, which has been looking at trying to implement risk stratification across 9 countries within Europe on a cloud-based platform, online platform. And that's for another time. But I have to say that not all the findings of StartBack trials are positive. And I've picked out 2 key ones that I think are really helpful. So Dan Churkin did a trial in the US, in Seattle, which was looking at risk stratification and getting family doctors to use risk stratification. And what was happening in this particular study is that the risk stratification was done before they came into clinic, and then the family doctors were told what's the risk status for this individual. And we found that although the screening was occurring and it was being done, the risk tool was being completed, it wasn't influencing and changing GP decision-making. So there was no difference in patient outcomes because the GPs didn't do anything different as a result. It's like, imagine back to the fire service, the automated system is saying that this one needs a high-rise building, and then the little fire engine with the short ladder goes. That essentially was part of the issue with that study. We were really struggling to make an impact on GP decision-making in that trial. And then we have the Target trial, which is Tony DeLito's trial, which is much more recent. And what they were doing there is they were trying to identify acute patients and then saying, let's spot the high-risk patients. And then with those specifically, let's send them to psychologically informed physical therapy, and let's see if that has a positive impact on those patients and their outcomes. Now, they managed to get a referral of 50% of the cases, and they talk a lot in their paper about that being a bit of a failure. They wanted it to be higher. But it wasn't too bad, but there's a struggle there to actually get a decision to be made according to the risk profile. But one of the other things is that they found that in terms of the results of those patients that got the treatment, there was a 50% transition of those acute patients to a chronic condition. And it was roughly the same regardless of whether they were in the intervention group or in the control, and they weren't getting through to a psychologically informed treatment. And that makes us think, well, what was going on around that intervention? Why did the intervention fail? Was there insufficient training? Is it around the fact that we need to be targeting more than just the psychological risk factors for these patients? Was it something around the acute patients? There's lots of questions about how do we do that and do it differently and do it better. So, but it's important to see that the StartBack findings, as we've taken it internationally, while they look great at Keel, they've not always been very, it's not been the same picture when we've tried to implement it, and it's really quite difficult. There's been lots of qualitative learning as well from different qualitative studies around the world, looking at what's the experience of patients, but particularly what's the experience of clinicians as they try and use StartBack and implement that. Some of the studies here are where they've been using it for a long time, others where it's just given to the clinicians as an idea and then they discuss what do you think about using this. And there are some positive aspects internationally around people saying, yeah, I do think this helps decision-making for patients. It does help at the system level in terms of efficiencies and making sure that we're doing a better job at who the patient sees. For a lot of clinicians, they say doing the training around the high risk has really helped my confidence to manage the high-risk complex patients. It's helped with interprofessional working with my GP colleagues or the clinical psychs or the occupational therapists or whatever it is. That seems to all work because we speak in the same language around whether low, medium or high risk. That's helpful. And they also say clearly, if we can get to patients who are at risk earlier, it's a little bit easier to treat them. So there's been some positive effects, but let's be honest, there's also quite a lot of negative aspects. People are worried about, in some countries, about the financial implications if they're trying to discharge low-risk patients much quicker and not get to see them so much, especially if a lot of their patients are low risk. There's also concerns around, am I going to reduce my own autonomy, my diagnostic skills, my ability to be really good at clinical reasoning if I'm using a tool like this? There's also concerns around time constraints, fitting it into short consultations. And we have seen it's been difficult to implement. And it's difficult to get a pathway that works well around this. So there are definitely negative aspects all around this whole idea of doing risk stratification. There's a particular one around, are we reducing the personalization of care for patients? And that's a challenging one. And clearly we don't want to be reducing the ability to personalize the treatment we give, but we do need to somehow use that prognostic information to make sure that patients are seeing the right person at the right time. And that's the balance we've got to try and think about when we're planning our services and implementing these kind of tools into practice. And certainly the last one I've put here is that it's often very difficult for people to find good quality training that gives them the confidence to manage the high-risk patients in clinical practice. So now when we move to the START MSK tool, what you need to understand is that the tool is a little bit different and the risk-matched treatment options are a little bit different. It's not just trying to do the same thing as StartBack. We had to include a non-modifiable factor, only one, which is the one around duration of pain, to make it work well at the GP consultation for all musculoskeletal problems. But broadly, the tool was still only looking at modifiable treatment factors. We haven't put in all those non-modifiable factors that I mentioned earlier, so that we are giving clinicians a really good opportunity to know what they should target when they are using the tool. But the matched treatment options are really what's the difference. So here, because this was a GP trial and we were trying to get family doctors, our general practitioners in the UK, to improve their decision-making, what we did is we found the evidence of the best treatments available for musculoskeletal conditions, put those into what was appropriate for low, medium, and high-risk patients. And particularly, we were trying to nudge decision-making around prescribing, referral, imaging, an in-depth review for high-risk patients that could be seen by the GP again, and SIX certification. And it was a big trial. It was 1,200 patients, and we randomized at the practice level, and we followed up for 6 months, and we were following up medical records and questionnaires with patients. So what do we find out? Well, if I look particularly at the changes in GP treatment decision-making over 6 months, we had actually 2,500 patients where we had that information. And here, what you've got in this table is we start with prescribing in the intervention practices and in the control practices and then in the intervention. Now, there were around 100 GPs taking part with roughly 50 in each arm. And what we see is we weren't making a big impact on prescribing. There was some increase in over-the-counter medication being given. We had a strange thing in that we saw a lot of increase early around opioid prescribing, but thankfully that wasn't repeated in the medical record in these patients. It wasn't a long-term prescribing problem of opioids. And it seems to be related to the fact that a lot of GPs wanted patients to have some analgesic cover when they were referring them to physiotherapy. In the non-pharmacological treatment side, we were seeing a doubling of the provision of self-management information, which was great. A lot of increased referral to physiotherapy. You can see that in the control arm, at the initial consultation, 10% of patients were being referred for physiotherapy and 60% in the intervention. Now, it's not that there weren't patients being referred over 6 months in the control arm. That number was much higher. But what was happening is when we looked at the initial consultation, the intervention GPs were noticing that someone was at risk and sending someone therefore on that first appointment rather than trying medication and doing a stepped care approach. So we were getting patients through early to physiotherapy, and that has real advantages in that the therapist was then saying it's easier to treat those patients because the problems aren't so entrenched. Across some of the other areas, we saw small reductions, but nothing significant, and you can see all the figures here. There were some reductions in orthopedic referral and in imaging, but because the numbers were quite low in our control arm, those weren't significant. So in terms of what we were trying to do, yes, we had some wins with prescribing, but also some negatives. We saw some increasing early referral for physiotherapy, which was good, and reductions in imaging. But it was interesting to see GPs weren't happy to take on the in-depth review that we wanted for high risk, and it had no impact on sick certification. And perhaps not surprisingly, when you look at our primary pain outcome, you can see now blue is the intervention, red is the control. This is the point of care, initial questionnaire, month 1, 2, 3, 4, 5, 6, and then the final questionnaire at 6 months. While patients were on a waiting list, there was no difference at all. And then eventually when they got through to see the therapist, yes, there was a bit of an effect, but not a huge effect happening. And we weren't in any way influencing the treatment in this particular trial, only the GP decision. And across secondary outcomes, there weren't big changes in patient outcomes. The qualitative results were very positive. GPs were saying, you know, we really liked using the tool because it did shift our musculoskeletal conversations with our patients to the more psychological and social issues, particularly for the peripheral joint problems, the shoulder, the knee, because they're already in the UK taking quite a psychosocial broad approach for backs and chronic widespread pain, etc. They also said it's quite nice to have that little warning about which patients might be high risk and become opioid dependent. And they said that that was helpful, although interestingly, we did see their opioid prescribing went up initially. And lastly, they said it really helps with the slightly, the patient who really has strong expectations about, for example, they want a scan and we don't want to give them a scan and we can blame the tool and say, well, the tool's not saying a scan's appropriate today. And so they can kind of help with that negotiation by using the tool. So the health economics didn't show a huge difference. That kind of showed us the costs were roughly the same. There was a small increase in cost of £7, but from a healthcare perspective, a slight reduction. But really the cost effectiveness study was saying if the place where we are seeing it being cost effective is within the high risk subgroup. Although that was a subgroup analysis that, you know, we have to remember that that was just in sort of explorative aspect of our analysis. So as I finish, what were the conclusions and what does it mean for us? Well, we can see from this big trial in GP practice that affecting a triage decision with something like a risk stratification tool, it doesn't have big impacts on pain and function outcomes for patients. You know, what's really going to make a big difference there is the high quality treatment that patients get around being, you know, having a therapist who's got confidence and is skilled to treat those complex problems. But what it does do is it nudges GP decision-making And what we were able to see is it was quite positive in terms of the ways that it was nudging GP decision making. We also saw that it's likely to be cost effective, but it's not hugely cost dominant. It's relatively cost neutral. But thankfully, it's not going to cost you any more if you try and use this approach within clinical practice. And we can see that it's quite scalable. It's something that you could do elsewhere. It feels simple. What we know from our start back is it actually isn't that simple to implement, and it's quite hard to do in practice. So where does this all lead us as I finish? Well, clearly risk stratifying has a place at a system level. You know, it helps some decision making, but it doesn't seem to help at that point on patient outcomes. You need to do something about the pathway if you're going to see that. It nudges behavior, but it's not going to be radical in any way. There are some things that GPs in the UK are happy to take on, like self-management information, giving more of that, more over-the-counter medication, more referral to physio, less imaging, when you support them to make that decision. But we know that there are some negatives, and we saw that, you know, the GPs weren't happy to do the in-depth review with the high-risk patients. They ended up actually referring even low-risk patients to physiotherapy, not just the medium and high, which was a shame. And that seems to be around them not particularly wanting to do all the red flag assessment. And, you know, if you open the door, they're quite happy just to send a lot of patients through to physiotherapy. So there were some positives and there were some negatives. And as I close, I just want to reflect back on the fire service. You know, risk stratification for them not only targets that initial response, but they're now starting to think in my area about where they put the fire stations, and they're putting them where the risk is highest. And I think we need a similar, you know, what's the chronic pain? Where is it in our community? And have we got the services and the resources all tied to look at that and try and work out, well, that's where we really need to do a better job. So I think we have made some mistakes. We have tried to see risk stratification much more as something that's a clinician individual tool and not enough as a system level tool. And what I think the results of these studies are saying is, let's keep remembering it's really important in terms of nudging that initial consultation. But let's also be realistic that that will only have a small effect on our patients. What we really need is our patients who are at risk to be identified and be treated with something that's effective and going to work for them. Now, I hope that's been useful, and I'll end there. So thank you.
Thank you very much, Jonathan, for this very informative talk, and for walking us through the journey of the fire service. I think it really helps us put a different perspective on those models and what works and what doesn't work. Maybe two quick questions specific to your talk in the chat. So one is about the psychologically informed physiotherapy. Can you just provide a bit of a definition in terms of, is that just a person inclined to approach that way, or a member of a specialized interdisciplinary team or a spatial designation?
Yeah, I mean, the way that we did it in Startback is we actually trained people for 6 days, and then we gave them lots of mentoring afterwards. And we had psychologists involved, and we had people with a lot of pain management experience, trying to help upskill mainstream physiotherapists. What we found ourselves doing is we were looking at, well, should we take the sort of, there's a more American approach where you give people lots of tools around anxiety or depression scales, and you say, when they reach this level, then you behave in this way. We decided not to go down that route, but to try and do training where therapists were helped to understand what does catastrophizing look like? What does depression look like? And how would you really explore that with your patient? And how would you treat that? And how would you support your treatment when you've got people with that kind of profile and that comorbidity going on, I guess. And we found that that was quite effective through a stem and leaf approach, where we got them to ask lots of questions, but they would know what they were seeing, what they were identifying in patients, what does depression look like, and what are some simple skills around managing that and helping overcome those barriers to recovery by encouraging the patient, graded exposure, all sorts of different skills, motivational interviewing, all those kinds of things, so that people felt really confident to manage that distress that they were seeing. And I think I'm not sure that there's one way that I could say this is the psychologically informed treatment approach, but I think it is around that confidence, and it's that sense of people being able to understand what's going on for this patient and have some simple skills and treatment approaches that they know are appropriate to support those kinds of patients. So my encouragement would be, wherever you are, to try and make sure that you're getting some training around that, particularly if you're getting high-risk patients. You don't want to be someone who, you know, has no experience, has had no training on managing those complex problems. And we've got to lean to our psychologists who, let's face it, this is their bread and butter, this is what they do really well, and make sure that we learn from them. In the same way that we want some of our mental health colleagues to learn from what we can do about the physical side with a lot of their patients. And it's about that integration so that we're a lot more holistic in the way that we manage our patients. Does that help? Does that answer that question?
Well, I think it's a good start to a conversation for sure. And like in terms of really what I'm getting from it is empowering clinicians to be able to address some of those broader factors that would come up in practice. And maybe the second specific question we have is about the why was the length of pain or pain duration included as a factor in that revised tool for MSK?
Yeah, that's a good question. So when I was talking earlier about modifiable risk factors, and StartBack only has modifiable, and we tried with Start MSK only having modifiable risk factors, we just found it wasn't proving predictive enough at the point of consultation. And the more non-modifiable predictors you add, the more you will shore up your prediction model. But each time you put in more non-modifiables, you reduce the ability of the clinician to know what to address and what treatments to address. So what we wanted was a tool with as many modifiable factors as possible. But if you start losing your predictive abilities, then you have to add in some of these non-modifiable factors. And so the reason for that was because it helped increase our area under the curve on when we were doing a ROC curve analysis in the way that we were trying to work out how predictive is our tool, to a level that we were happy with. It might be that in the future people say, well, in our setting, we're going to have 2 or 3 of these non-modifiable risk factors to make something like this really predictive. And that's something we need to be checking, because as it gets used in different contexts and in different situations, you will find that the risk prediction, the accuracy of that reduces each time you take it to a new setting. So that's something that is an important piece of work that we need to do. Another thing that I will just comment on is that we know that GPs in the UK aren't very happy about asking 10 questions with every single patient. And in the future, we're going to need to move to automated risk prediction. The fire service lady, you know, the person who you ring and say, I've got a fire, they don't ask you 10 questions. They have it all automated in the background because it really is a short conversation. But we need to recognize often consultations are short, and it's a real barrier if you have all these questions for people. So we need to look at new ways that we can do that using the medical record data and using that automatically to identify risk patients, because I think in that context, that might be working better. But there are some downsides of that. If you just tell them, as we saw with the American study that Dan Churkin led, if you just give clinicians the answer and don't ask them to ask any questions, they don't engage in that whole psychosocial piece in the consultation so much, and it matters less to them, and it then doesn't influence their decision making. So that there's a balance to be made here in terms of how we implement this and do it well, and it'll depend on the setting that we're in, I think, as to how we do it and do it well.
Great. So thank you for those clarifications, and also for the food for thought in terms of balance between prediction and integrating the clinical context that you're working in. Fantastic. So then I will introduce our final speaker for today. So Luciola da Cunha Menezes Costa. So she's a Brazilian physiotherapist with a PhD from the University of Sydney in Australia. She's now an associate professor of the master's and doctoral programs in physical therapy at the Universidade de Sao Paulo in Brazil. She's also a former associate editor of the Journal of Orthopedic and Sport Physical Therapy. She has completed clinical trials, prognostic studies, and systematic reviews in low back pain. And today she's going to talk to us about those type of models specifically applied to the Brazil context.
Thank you. So thank you, Gabriela, for the introduction. And it's a very pleasure to be here today talking this webinar. And it also is a very pleasure to talk with two persons that I admire a lot, Alice and Jonathan. So thanks for having me here. Just try to share my screen. Are you seeing my screen now?
Yes, that's good.
Yeah, that's great. Okay, so after the great talks we have today, I will just give a simple example how hard it is to try to implement complex intervention in a different country. So it's not working. Yes, it's working. So let's talk first about COVID before we talk about back pain. So thinking about the COVID scenario, we have a disease with a well-known cause. We developed treatment vaccines targeted to fight against the virus. Some vaccines works with a very good result across the countries and the planets. And however, regulatory agencies require for additional data for potential subgroups. And also these agents want that vaccines work across the whole planet. So therefore, multi-center trials were needed. So just take AstraZeneca vaccine as an example. There were 4 clinical trials, 1 in South Africa, 1 in Brazil, and 2 in UK. And the results of these trials were very different. So even though we know the cause of the disease, the effect of treatment was different across different populations. So this means that countries matter, peoples matter, and health system matter. So let's talk about back pain now. Well, this looks a little bit more complicated because back pain is a multidimensional disease and we have no idea about the causes, and health system across different countries are very different and also have different priorities. So probably it's expected that complex intervention will not work similar across the globe. So this is slide coming from Jonathan's presentation at DAC-CPT in 2015. This slide shows the amount of work and time to develop the StatBack screening tool and also to make it happen from its validation to implementation. And the research on risk stratification model is still ongoing. I really like this slide because this was the exact scenario back in 2013 when I started to conduct a prognostic research related to back pain here in Brazil. So at that point in time, I would like to be part of this list, as my first plan was to conduct a randomized controlled trial to replicate the study on the efficacy of the risk stratification approach here in Brazil. So although our research group has a large experience in conducting clinical trial, we raised a number of questions before you could apply for grants to fund this trial. Most of the questions was related to barriers and cautions before you start a larger trial. As we all know, that subgroup trials need a very large sample size. And the first barrier was that the StatBack screen tool was not available in our language. And as we know our funding agencies quite well, we are aware that without a proper cross-cultural adaptation, I couldn't apply for any grants to conduct the trial here. So as we can see, the StatBack screen tool was just available to be used in the research and in clinical setting in Brazil in 2014, almost 6 years after its first publication. So overcoming this barrier, the next step was to test the StatBack screening tool in a Brazilian clinical population. So we conducted a series of studies using the StatBack screening tool into different populations and different settings. So the first study was a prospective cohort study with patients with chronic low back pain seeking care at physical therapy clinics in a public service. One of the aims of this study was to describe the course of clinical outcomes in patients in each subgroup over a period of 6 months. So looking at this graph, we found that pain intensity, disability, and global perceived effect levels were consistently higher in patients classified in high-risk group compared to those in the medium and low-risk subgroups in all time points. And similarly, the score for the patients in the medium risk subgroup were also higher compared to the patients in the low risk subgroup in all time points as well. So clearly, we have 3 different pathways of prognosis based on risk stratification, which were very similar compared to different countries. So then we also wanted to investigate the percentage of patients classified in each stratification group when we used the STAT-X tool at different time points, with the aim just to understand which will be the best time to use the stratification care model in our country. So the patients answered the STAT-X tool at initial assessment, and then they answered again after 5 weeks of treatment. And also later, we applied the tool at 3 and 6 months just to classify the percent of patients in each risk group classification over time. So as a result, as you can see, when we use the STAT-X tool at initial assessment, the majority of patients here in Brazil were classified as have a high risk of poor prognosis. But after treatment, this classification has changed a lot. And of course, we expect this change as all patients have received treatment, and also because the risk tool is compounded of only modified prognostic factors. But as you can see, after 5 weeks of treatment, the majority of patients now are classified as having low risk of poor prognosis. And this classification tended to be more similar or stable, if I can say so, over time. So finally, in this study, we also wanted to investigate and test the predictive ability of the STAT-X tool when it was also applied at different time points. So firstly, we look at the ability of the tool when it was applied at initial assessment to predict disability, pain intensity, and global perceived effect at 6 months. And then we also looked at the predictivity ability of the tool when it was applied at 5 weeks to also investigate the prediction of outcomes. So to evaluate the ability of the STAT-X tool to predict clinical outcomes, we construct hierarchical linear regression models for each outcome and also into different time points. So to do the analysis, we performed 2 blocks of analysis. In the first block, the dependent variable was the outcomes, disability or pain or global perceived effect, assessed at 6 months. But this model was adjusted for age, gender, duration of symptoms, and also the outcomes itself at baseline. And then we built the second block of analysis. And in this second block, we use the same variables as those in block 1, but we just add as an independent variable the STAT-X tool classification to investigate the addition of prediction in the model. So what we found that when the STAT-X tool was used at initial assessment, it was not able to add prediction in the model. But when we used the STAT-X tool after 5 weeks of treatment, the tool adds prediction in all 3 different outcomes, and with an addition of almost 13% of the explained variability in the model. So looking the results together, we found that the percentage of risk classification at baseline from our cohort were very different than cohort outside Brazil. This may be explained due to the clinical setting. For example, here we are recruiting patients in the physical therapy clinics. But it's important to highlight that this is the expected pathway of care in patients with chronic low back pain in Brazil, especially talking about public servicing. And also at that time point, the start back screen tool did not add prediction at the initial assessment. These findings suggest that applying the start back screen tool at initial assessment may be not the best time to implement the risk stratification approach in that system. So, however, when we use the start back screen tool at 5 weeks, it adds prediction in the models, and also the percentage of patients in each risk group classification look more stable over time, and therefore it could be considered as a good time to decide who you need more care and who could be discharged from the system. So we want to understand this number a little bit more, and we wanted to see whether we could find similar results in acute population in a different setting. So therefore, we conducted the second study, which was a prospective inception cohort of patients with acute low back pain seeking care at the emergency department. Some people might find it weird to use the start back screen tool at the emergency department. However, looking at these graphs, it seems that the recovery rates from emergency department and primary care are very similar. So I have compared the recovery rates from our study to a very similar study conducted in primary care in Australia. And as we can see, by 1 year, the recovery rates from the emergency department here in Brazil were very similar compared to the recovery rates in low back pain patients presented to a primary care in Australia. So we decided to use this population to investigate the same questions we did in the chronic cohort study. So firstly, we also want to investigate the percent of patients classified in each risk stratification group when you collecting data in different time points. And as we can see, we found a very similar results compared to the chronic cohort. When we use the start at initial assessment, the majority of patients were also classified as have a high risk of poor prognosis. And after 6 weeks, the classification of the patient changed a lot. But here, it's important to highlight that in this acute cohort, the patient did not receive treatment between both assessments compared to the chronic cohort. They have just received the routine care at the emergency department, but we believe here that the change happened because of the good prognosis of patients with acute low back pain. And also, when you look at the classification of patients, when they use the start back screen tool at 6-week assessment, the classification tended to be more stable or similar looking over time. So then after this, we also want to test the predictive ability of the start back screen tool when it was applied at 2 different time points, exactly the way we did in the cohort. So we found that the start back screen tool was not able to add prediction at disability model at 6 months and when it was assessed at baseline, but it adds only 3.8% of the explained variability in the model. But however, when the start back screen tool was also applied at 6 weeks, it was able to predict also pain and disability, and the results were very similar with the chronic cohort. So just looking all the results together, look at the acute and chronic patients, we concluded that the best time to use the stratification approach in Brazil based on these studies should be about 5 to 6 weeks from baseline. So if we would implement a stratified care approach in Brazil, it would be like this, like firstly, all patients will receive minimal care, and then we provide a stratified approach in giving more care for those who need most. So with this in mind, we decided to conduct another cohort study just to investigate the feasibility of implementing this approach. So we did the third study, which was also a prospective inception cohort of patients with acute low back pain, also seeking care at the emergency department in a public service. And what we have done in this cohort, like the patient who seek care at the emergency department, they were assessed and received usual care at the emergency department. And then our research team provided the patients a course of minimal care, which was every week we send them videos contain information and education to support self-management and to advise to stay activity, and also some information about attitudes and beliefs towards back pain. And then at 6 weeks, we use the Stratified screen tool to stratify the patients and also use the stratified approach to treat them. So basically the patients on low risk was discharged as they have already received minimal care. Patients at medium risk, they receive supervised exercise and plus manual therapy if they need it. And in the high risk, they receive supervised exercise plus manual therapy if they needed it. And we also addressed psychological, social factors by a trained PT. So, and then we reassessed these patients at 3 and 6 months. Reassess to look at the clinical outcomes. So in this cohort, we collected data regards to clinical outcomes. We also collected data related to cost, and we also collected data related to implementation of this approach in the system. So unfortunately, I have tried my best to analyze all the data before I could speak here today, but by the moment, we only have analyzed the data regards to implementation. And as we can see from this table here, we found excellent levels of acceptability of the patients, because this implementation was on the perspective of the patients, not on the healthcare system. And think about the patients, they have excellent levels of acceptability, excellent level of appropriateness, and also we found a good levels of feasibility and good level of fidelity. So just to summarize in my talking and in my conclusion, we have conducted here in Brazil a series of study on a stratification approach. And we think that this study we have conducted allow us to understand a little bit more about the risk stratification approach in our country. Also, this study allows us to fit the risk stratification approach, which was developed in the UK, to our health system. And we also believe that with the results of this study we have conducted so far, we are now more confident about to conduct a randomized control trial. We are more confident about recruitment, about the acceptability of the patients to be receiving more care later on after they seeking care. And we also think that with the results now we would be able to apply for a program grant to conduct this larger clinical trial. And finally, my thoughts is about the efficacy of the clinical trials related to risk stratification. And I think maybe RCTs conducting countries other than UK might find different results due to the difference on health system or the way they use the stratification model, or even though it was different because of different cultural aspects, or even because the treatment effects are truly different. So this was just an overview. I want to show you guys how hard sometimes it is to try to implement and use the approach developed in different countries to a new system in different culture. So I'd like just to thank everybody to have me here.
Thank you very much, Lucilia, for helping us understand all the challenges, but also the perseverance involved in translating those novels into specific practice of care. And there's a few questions in the chat about this, like, do you have any recommendations, or what were the key points for you to be able to adapt to your own healthcare system? What was the key for you to have those successful initial trials?
I think the key question for us was like, health system in Brazil, I think is in different countries probably be the same. They are not open to try to implement something new. I think it takes time to convince the people to try something new in the system. And for us, the big challenge was like where we should recruit patients to do this trial. Should we recruit patients from chronic patients or in acute patients? And we thought probably it would be a good idea to recruit in patients with early on the disease. So we found another challenge where find these patients, because in Brazil we have a very different health system. Like we have the public service, and the pathway of the public service in Brazil is very similar to other countries, but we have also the private service, and a lot of people have a private service in Brazil. So in this service, patients can go direct to surgery, to orthopedic for more high level of care, and it is hard to convince where we should give more care, because the patient has access to extra care if they need it. So for us, this was the biggest challenge in the beginning. But then we start to try to understand where we should use, and also if the patients you'll be happy to use. We still have more challenge to overcome. Like everything I have done was on the patient perspective, and because I didn't have numbers to show to the stakeholders for the hospitals. And now with the numbers, my next challenge is try to show them and convince them. Probably is a good thing to try to implement and do another implementation research to show them if you are able to train a physician, if they will be able to use, or we have a more challenge to overcome to try to implement this here.
Yeah, sounds like you have a good solid foundation to build up. So I will invite all the panelists back. There's a few questions for all of you. There was one that came early on about health literacy. Like, do you look at health literacy in patients with back pain, and how is that a factor to take into account in those step care or stratified models? So I don't know who would want to take a go at this. Jonathan?
I'm happy to have a go at that. We actually did a subgroup analysis on the StartBack trial, which found that there was a real issue for low-risk patients who had low deprivation scores. So they were coming from a very deprived neighborhood and background. And we didn't actually have health literacy, but we suspect that health literacy is very closely correlated to that index of deprivation. And probably what we need to be careful of is that we're not saying low-risk patients keep away from services and here's just some leaflets, because they don't have the health literacy and the confidence then to use that information and to use it well. So we need to be very careful about that. There was a recent paper that I'm involved with someone called Karen Walker-Bone from the UK, and she's an epidemiologist, and she's looked at over 220,000 patients who've called one of our emergency sort of call lines in the UK in the NHS. And it shows that patients from the most deprived areas who are low risk have worse outcomes than high risk patients from the most wealthy areas. Okay, so that's an example of a non-modifiable risk factor, which is incredibly powerful. Okay, and that's why we need to realize StartBack is not measuring the non-modifiable risk factors. And we need to be careful that we don't think it is telling us everything about risk prediction. It's only telling us about the modifiable factors that are included in the tool. and that's helpful because that allows us to do something different. Because managing deprivation and health literacy is very hard for an individual clinician to do something big and intervene on that. So, but it's worth us recognizing, absolutely, health literacy is huge. It's a prognostic factor, and we do need to acknowledge that and make sure that our low risk pathway, if we've got people with low health literacy, it's not just giving something to them that's not helpful, because the data shows that that's a real problem if you do that.
Great.
I just want to, because just to complement a little bit, I agree. From our study in the emergency department, we were shocked, like none of the doctors advise and talk with patients. And when our research team just sat down and explained and talk and given more information about education patients, and because we conduct in public service, and we have a lot of patients with no idea in literacy about this stuff. And I think for them, they were very grateful to listen us. And you can see the big difference, how a greater communication can do and make difference for patients.
And Alice, did you also want to comment on this?
I really agree with everything said here. I just want to point to how important it is to discuss this, because patient information and education plays such a huge role in the management of back pain. And it is important that we don't consider the low risk management as something that's just like go home and wait and see. Previously, I think the basic care was have some painkillers and see what happens. But now the minimal care is actually to have information and advice and a dialogue about back pain that is adapted to individuals' needs. So basic care is really challenging for both clinicians and patients, and we have to be much more wiser about than we are now, how we address individual people's needs also in terms of health literacy differences.
Yeah, those are all very good points. And as I know, at least in Canada, the healthcare system is moving towards more of a hybrid version, or where there's more and more virtual care that is also being integrated. And so that might add another layer of issues in terms of disparities in access and like technological literacy also that might come into play. There was another question about adaptation of this tool, especially in healthcare settings where the referral pathways are not clearly defined. Any comments you might have about this?
Maybe I'll go first with that one. One of the things that I'm really excited about presenting START MSK trial is that people can see an example of how we in the UK have adapted our approach for a slightly broader set of conditions, and now less sort of physio and more general practice focused. And I think that hopefully inspires people to say, we're allowed to adapt it. We're allowed to make it work for our setting, because we never intended that this was going to be the only way that risk stratification should work internationally. And I would encourage people to really map out their pathway, work out where are the blind spots, what's really good and evidence-based options, and how do they use the risk profile to help match people to the evidence that we have. And clearly it's helpful if that's a system level early sort of decision, but there are problems with start back being used too early. So, so this is the tension. And it might be that people have to do their own prognostic study and actually work out what are the key prognostic factors. Do we need a mix of non-modifiable as well as modifiable to make the risk stratification really work in our setting? And I feel like we're just at the beginning of this. I'm sure that risk stratification has a place, but exactly how we do it it's going to take us a while to really answer all of those questions. I love what Luciola's doing, because I think she's being logical, she's being scientific, she's working through a process to try and answer some of those questions in her country and in her setting. And I think I would encourage others, just take a similar approach, look at that example, and try and work out what do we need to be finding out about the prognostic side, about identifying the right people, and then about the matching of treatment, and what can we do to try and improve the matching of patients to evidence-based treatment. I hope that helps.
If I can just complete, like, I agree, it probably if your country have a different health system as we do have here in Brazil, probably the implementation will be different in different health systems. You don't need to have the same implementation in one country. It can be like you can think, this is what we're thinking about to do here in Brazil. Probably if the patients are in the physical therapy department, probably we do one step before, which is the patients, but in another settings, probably will be different as well. So we need to adapt it even in your country, in different settings.
I just want to acknowledge the importance of that question. I started out with saying that models of care are related to all parts of the healthcare system and governance and organization, and it is implementation is therefore so complex, and it taking a model of care meant to help clinicians making treatment decisions is not sufficient for it to be implemented. You have to figure out how that might fit with the organization and laws and whatever is in the country. So there are so many aspects of implementation and so many stakeholders in a healthcare system. So yeah, as Jonathan said, mapping out what does this look like in my country, and what steps would it take to move towards what I'm aiming at.
Yeah, definitely. I think there's a few questions that are all around this, like how do we adapt it to different healthcare systems? So I think that shows both the interest in those type of models, but also the challenges of concretely how do we go about this. And maybe Alice, another question for you. You mentioned that there's no research that compares sort of head-to-head the step care and the stratification. But there's a question about, do you have an idea of which model is most commonly employed currently in practice and why?
Yeah, I think that might be quite a sad answer to that, because I actually think that we know surprisingly little about healthcare for back pain globally. So I couldn't even say what is the model of care used for back pain care in Denmark, because I know so little about what decisions are made in healthcare systems and among clinicians, even in the country that I'm myself as a researcher in. So, and I know from global data that is probably very much the same all over the world. My feel would be that without clinicians or healthcare systems being very clear about the model of care, that it is mainly a step care approach. We start with something, we see if it is a success or not. If people fail, we'll come up with something else, but it's not very intentional how that is implemented, and they are often not like fixed timelines for reassessment of people when she would then handle on insufficient improvements and so on. I think actually the stratified care model developed by Jonathan and colleagues in Keel is by far the model that has been systematically tried, implemented in most settings. And I think that is really, Jonathan is very humble when he presents the results from this, but I think so much has been learned from building on this really great work and try to see how it works in different settings. So I think it's really to pursue these models and keep figuring out how can this work in different places, but for now, I think really there's few places where there is a structured, implemented model of care of any kind.
Yes, thank you for this very thoughtful response to that question. Maybe I have time for one last question. So one is asking about the MSK, and the START back looks at the individual level, but we know that disability is determined partly or maybe mainly by social determinants of health. So do you see in the future a social MSK screening tool or a unified version that would include those domains?
I'm happy to start with that one. I think it's so true. I mean, the example and the question around health literacy tells us that, you know, these social determinants are huge, and it's not just for back pain, is it? It's across all areas of health. We need to recognize that, and it's in my mind there absolutely needs to be a hybrid model. You know, in the same way that they put the fire engines where the fire risk is greatest, we need our healthcare resources put in the communities where we have the most burden and problems. But within that, we also then need to signpost, and we need to decide and make good decisions on what we do with individuals. And I think there's a role for finding risk stratification as part of the decision making. It's not, you know, prognosis on its own is only part of the picture. Diagnosis is hugely important as well, you know. And absolutely the idea that we have to step to give people, everyone needs a basic, you know, Alice is absolutely saying the right things. But so I would argue it is the future will tell us that we need a hybrid model. We need to have some things around social determinants, and particularly non-modifiables from a clinician point of view, and then some things which are a bit more modifiable focused, which helps the clinician, okay, out of the treatment options in my, you know, in my basket here, I can choose these ones as the right ones for this patient. So absolutely, it needs to be a hybrid model in the future from my perspective.
Fantastic. So I want to really thank all three of you for taking the time this morning to share your research and your thoughts about those models. I hope that the attendees have enjoyed those presentations as much as I did. And hopefully we will see you in Iasp next year, so we can continue talking about these models and applying them to different healthcare systems. So I wish everyone a good rest of your day, and thank you for being here.